Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The P&A is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The P&A is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many of the questions as possible. Today's webinar, Aggressive Pituitary Neuroendocrine Tumor, What to Know, is presented by Dr. Mario Zuccarello and Dr. Jonathan Forbes. Please hold while there will be a brief delay while we change presenters.
Okay, so I'm just looking, trying to share my screen here.
John, see if you can share the screen so I can start.
Yeah, I'm sorry, I'm having a hard time. Maybe I'll just email you the presentation if that's okay, or.
Let me see, John, if I can share the screen. Let me see if I can do that.
Let's see, let me go ahead and send another prompt.
Okay, can you see me? Can you see my screen?
I do not see your screen here.
Because I have the presentation there. So let me see if I can share where I can share my screen. Let me see.
Do you see up at the top where it says show screen?
No. Show, yes, but I don't think want to work. Let me see. Okay, let me see if I can do that. I think I probably see this. I'm trying to. Okay. Okay. No, I see sharing, but
Yep.
I don't know why it doesn't want to show. Can you see the screen?
Oh, here we go. So it actually just popped up. So my screen here.
Can you see the screen?
There we go. Yep, we see it now.
Yeah. So so can everyone? Okay.
So let me start.
There we go. Dr. Zuccarello?
Yes. First of all, I want to thank P&A for the opportunity that Dr. Forbes and I has to present today. And we picked this topic because I don't think it's been discussed in the past. And I think it's a topic that is generated from the interest and the needs, actually, of the number of patients of ours and the caregivers to understand why a pituitary tumor sometimes can be aggressive and why another pituitary tumor can be cured. So it's a question that we receive from our patients many times. How comes that this tumor is recurred while the other one is not? So I hope this will generate questions and interest. So let me see the next slide. Okay, I guess we are. So this is me on the left, Dr. Forbes. So I think it's really important that the naming for pituitary adenomas has really changed, and now the name is gone from a pituitary adenoma, very classically reported as a pituitary neuroendocrine tumors, what they call a PITNET. Okay, and some of this PITNET can be atypical, can be aggressive. Also, some of these tumors, as you already know, can be hormonal secreting, and some of them not. And so, depending if they are secreting hormones or not, you have a different way to treat this. And so, the histopathology also has changed, and so we need to make any effort to understand in advance whether a tumor can have an aggressive behavior or a tumor can be cured and be considered benign. So I remember many years ago when I started neurosurgery and started taking care of patients with pituitary tumors, was enough to send a specimen to the pathologist. The pathologist stained the tissue, and the tissue was acidophilic, mostly in case of acromegaly, was basophilic, mostly in case of Cushing disease, or chromophobic, which is some of the not secreting necessarily the type of pituitary tumors. So this was pretty simple, and but really did not help much. And so the World Health Organization in 2004 start defining these tumors based upon the immunohistochemistry. And so depending on the hormones, there was a growth hormones, was a prolactin, was the FSH, so follicular stimulator hormones, or LH, can be ACTH, TSH, or pluri, which means more than one hormone, or no, means practically no hormone, not secreting. Okay, so you can see that from a simple description under the microscope. Oh, this is acidophilic or basophilic or chromophobic. We go now in a much more refined classifications based upon the hormones. But this really has improved certainly our ability to treat patients, but not really defining which one is more or less aggressive. Now, in 2017, we went into much more technological advanced way to self-classify these tumors, and so the transcription factors, so something which is related to genetic factors, has been used to classify these tumors. So the questions is, do we have enough knowledge to identify pituitary tumors which has a risk of recurrent or in general an increased risk not to be cured, which is really for a benign tumor by definition is quite worrisome. And so I think this concept of atypical adenomas, which was in 2004 introduced and was based essentially upon how fast these tumors can grow and double in size. So this Ki-67 is an index of growth, how fast this stuff will grow. And the immunoreactivity of P53 is nothing else than also a marker of growth. And mitotic count is the same stuff. It means mitotic means that the cells are in a phase of divided. So the more phase of division you find, the higher is the chance that this tumor is atypical. And so and then we go to the modification in 2017, which we just already shown with individual histotypes, which may be more or less predisposed to atypia and recurrence. So I think at this point, I will ask Dr. Forbes to they describe the concept of pituitary carcinoma, which means nothing else than a pituitary tumor, which behaves like a cancer. Okay, so and this is very, very important, and I think will capture your attention. So, John, if you want to keep take from here, that would be great.
Thanks so much, Dr. Zuccarello. And so, just in line with what Dr. Zuccarello had said, this presentation is all about these rare type of pituitary tumors that are predisposed towards recurrence. And just to take a step back to this slide, like Dr. Zuccarello had mentioned, so in general, we look at three particular markers. So when the tumor is resected and sent to the pathologist, they do something called a Ki-67 labeling index. And so Ki-67 is expressed in growing cells, and it's not expressed in quiescent cells. And so in general, if you have a large percentage of cells that are growing, that's an unusual thing, and that's more indicative of an aggressive tumor. So you can see here that a Ki-67 labeling index greater than 3% indicates a tumor that's prone to recurrence. And in a case to follow, I'm going to show you a case of a tumor that we removed that had a Ki-67 of 75 to 80%. And so 25 times what would be considered abnormal. And I'll show you a breakthrough that we had at the University of Cincinnati that we're very excited about. So, in addition to the Ki-67 labeling index, we also look at nuclear staining for p53 immunoreactivity. And so that's just when it's a gene that when it's lost can predispose tumors to aggressive growth. We also look at the mitotic count. So a mitotic count greater than 2 per high power field is also indicative of a more aggressive tumor. And so, so what's the difference between an aggressive pituitary tumor and a pituitary carcinoma? Well, a pituitary carcinoma is defined by the occurrence of metastasis or non-contiguous spread of the tumor to another site of the body. So fortunately, this is a very rare phenomenon. And so you can see 0.1 to 0.4% of pituitary tumors. Oftentimes with pituitary carcinomas, that Ki-67 is going to be greater than 10%. And when the pathologists look at the tumor, they're going to see evidence of neoangiogenesis. And like Dr. Zuccarello had mentioned, these newer techniques where we look at immunohistochemistry and where we look at the DNA of the tumor, the transcription factors, can help us better decide how aggressive the tumor is. And so it's an active area of research, specifically looking at these molecular markers to give us not only an idea of how invasive a tumor is and how prone it is to recurrence, but also how to treat that, how best to treat that tumor. So our goal is early characterization of aggressive pituitary neuroendocrine tumors. So pituitary carcinomas typically present in the 3rd to 5th decade of life in patients with pre-existing pituitary tumors. Historically, the survival rates of pituitary carcinomas have not been good, ranging from 57 to 66% at 1 year. So more recent studies have demonstrated slightly improved figures, including a study with a 71% overall survival rate at 2 years, reflective of improvements in therapy. Currently, temozolomide is the only chemotherapeutic agent recommended for AP-NETs in clinical practice guidelines. And in the case that I'll show, we tried temozolomide, and initially the tumor did not respond. And I'll talk a little bit more about that. So temozolomide is a DNA alkylating agent that causes frequent base excision repairs, ultimately triggering cell death. So the DNA is alkylated, and then mismatch repair detects the alkylation, and that ultimately triggers cell death. So it's important to know that TMZ is only truly effective in tumors that have functional mismatch repair. So many tumors do not have functional mismatch repair because when the DNA repair mechanisms go out, it predisposes the tumors to additional abnormalities in the DNA, which is oftentimes what you see in different types of cancers. Unfortunately, only 37% of patients with atypical pituitary adenomas respond to TMZ with an average time to progression of 1 year after cessation of therapy. It is believed that temozolomide is only cytotoxic in tumors with a functional mismatch repair system. Data suggests that loss of the mismatch repair genes MSH2 and MSH6 is associated with treatment failure. And so in general, there is a need for better chemotherapeutic options. So this is the case we'd like to present. So this is a 57-year-old gentleman who presented with visual deterioration. And so you can see the MR images to the right. So the upper two images are after contrast administration. And so you can see kind of the typical snowman appearance of a pituitary adenoma. And so that the tumor is elevating the optic nerves, which are not well visualized in these images. And the patient had suffered visual deterioration because of this tumor. So, and on examination, he had something called a bitemporal hemianopsia, which is a particular pattern of visual loss that's often seen with these pituitary tumors. So the MRI was read as a cellular mass with supracellular extension and impingement of the optic apparatus. And so with all of this in mind, we scheduled him for a surgery. This was back in January of 2019. So the patient underwent an uneventful resection of the tumor. And so you can see the preoperative MR image at the top of the screen, and then the repeat MR image at the bottom of the screen after surgery. So you can see that all of the tumor was removed. The surgery was very uneventful. Following surgery, the patient's vision normalized. So of interest, when our pathologist looked at the tumor, they found a sparsely granulated corticotroph adenoma. So that's a pituitary tumor that stained for ACTH, but didn't actually produce a hormone like most tumors that stain with ACTH do. In addition, the Ki-67, as we mentioned before, was 75 to 80%. So it was 25 times above what's considered the upper limit of normal. And so this was a very aggressive tumor. So even though we had removed all of the tumor on MRI, because this was such an aggressive pituitary neuroendocrine tumor, we decided to proceed with radiation postoperatively. And so in this slide, you can see his patient's original presentation. And to the right, you can see the immediate postoperative MRI, which was clean of tumor. And then the patient was sent for fractionated radiation therapy. So we treated the surgical bed with 66 gray. That's a quantity of radiation that's often used in 30 fractions. And he completed this in February 2019. Following radiation therapy, as is sometimes commonly encountered, he developed the thyroid hormone levels were a little bit lower, as were his testosterone levels. So we started him on thyroid medication and testosterone, and that's often encountered after the radiation.
John, can I stop you for a second?
Oh, yes, please.
If you go back one slide, I think it's important for the audience, for the attendees, to understand that if you look at, because one question can come very easily, and I hope it will from you guys attending this, can you identify on the MRI anything which is suggestive that this is not a benign tumor?
Yeah, I think that's an excellent question, Dr. Zuccarello, and I think that
on this MRI, really, I cannot see anything which is different from many other pituitary tumors.
Yeah, and I think I would be in agreement with that statement. And in fact, going in, we were expecting a benign pituitary tumor up until that pathology report came back.
So, because this is important, because it's been particularly for somebody who will be asking the questions, can you preoperatively have anything which identify an aggressive tumor? It's been suggested many times that if you have invasion of the cavernous sinus, which is all the way each side, bordering these tumors, it maybe is more aggressive, but in reality, it doesn't seem to be the case.
Yeah, no, I think that's an excellent point. And so this patient, so after surgery and radiation, we obtained a repeat MRI 6 months postoperatively. And at this time, there was still no evidence of tumor recurrence. However, in May of 2020, so now we're 14 months out from the surgery, the patient returned with a new onset 6th nerve palsy. And so you can see a recurrence of tumor there, which is kind of involving the right cavernous sinus near where that 6th cranial nerve, where it traverses all the way up into the eye. And so at this point in time, we met with the oncology team, and we did not feel that additional surgery was really the right option. And so this patient's case was presented at Brain Tumor Conference, and in line with what's considered the gold standard for medical treatment of these aggressive pituitary tumors, we decided to try temozolomide. Now, of particular note, this patient's, we mentioned the mismatch repair. This patient's tumor had evidence of genetic alteration in the mismatch repair gene. And so, I think we were concerned that TMZ might not work, and in fact, it didn't work. So we didn't see any improvement in the MRI on his examination. So, we had discussed in May of 2020, 14 months post-operatively, the patient returned with a new cranial nerve 6 palsy. The repeat MRI we had reviewed. The patient received 3 cycles of temozolomide. In addition to the MRI, which we followed, and the clinical exam, his ACTH levels, which had been elevated, remained elevated post-therapy. And subsequently, his MRI, and initially after the original surgery, his ACTH levels had completely normalized. And his subsequent MRI demonstrated tumor progression. So at this point in time, we used next generation DNA sequencing. So we went back and obtained a specimen of his tumor that had been saved from the prior resection, and we used a new impact platform that allowed us an in-depth study of the tumor's DNA. So we identified some specific somatic mutations in the tumor DNA that are mentioned there. And so following attainment and evaluation of the tumor DNA, we met as a group at Brain Tumor Conference and discussed the next step in management. And so we really felt like the patient would be a good candidate for something called immune checkpoint inhibitors. And so if you look at the illustration at the top of the screen, so this kind of reviews the mechanism of immune checkpoint inhibitors. So T cells, which are the body's immune cells, express receptors. And occasionally these tumor cells can activate these receptors, which serve to downregulate the body's immune system. As we all know, the body's immune system is extremely important, not only for infections, but for fighting cancers. And so this downregulation is one reason why these tumors are able to spin out of control. And so after reviewing the tumor DNA, we placed the patient on ipilimumab and nivolumab. And so ipilimumab works by blocking CTLA4, which you can see in the illustration above. So that's a receptor on the T cell when activated by the tumor, which downregulates that immune response. And so the medication actually binds to that receptor and blocks it and prevents the tumor activation. So nivolumab blocks a different checkpoint molecule called PD-1, which and helps to protect PD-1 when activated, also helps to protect tumor cells from being attacked by the immune system. And so here, so you can see that in May of 2020, the patient noted the recurrence. In February of 2021, you can see the repeat MRI, which incredibly showed that the tumor had resolved completely. And so on the immune checkpoint inhibitors, the immune system was able to reactivate and to clear this patient's tumor. And so by this point in time, his right cranial nerve 6 palsy had completely resolved, and the repeat MRI was completely free of tumor. And so now we're almost 1 year out from this scan, and the patient remains tumor-free at this time. So, again, this is a look at May of 2020 when he had the recurrence, and then February of 2021 when he had complete resolution. So the patient completed his 4th and final cycle of ipilimumab on November 2nd, 2020, and finished his 10th and final nivolumab cycle in April of 2021. Surveillance MRI in September of 2020 was again notable for complete resolution of the tumor. And to date, his right cranial 6 nerve palsy has resolved. He has no issues with double vision or with moving his eyes. His vision is perfect. So notably, the immune checkpoint inhibitor therapy was tolerated pretty well, with the exception of eosinophilia, which was noted on his blood counts that we obtained. And so, so he was totally asymptomatic, but we noted that some of the immune cells, the eosinophils in his blood count went up a little bit. And so we put him on prednisone therapy for that, and there were no other issues. And so this was possibly the result of the immune checkpoint inhibitor therapy. We're not entirely sure. So, so what's the history of Ipi and Nivo? So in 2018, Lin et al. Was the first to report successful treatment of the first case of an ACTH secreting pituitary carcinoma with ipilimumab and nivolumab combination therapy. However, this case had a really short duration of follow-up, and so since that time, there have been 4 case reports of ACTH staining pituitary tumors treated with immune checkpoint inhibitor therapy. So we're talking still, despite all of the advances that we've made, that this is one of a handful of cases that has been reported in the literature. And this case was presented at our last meeting of Congress of Neurological Surgeons, and we think really is demonstrative of the potential benefit of this immune checkpoint inhibitor therapy. So this report is the first case of ACTH staining aggressive pituitary neuroendocrine tumor with somatic mismatch repair deficiency and temozolomide resistance related to that was treated with immune checkpoint inhibitor combination therapy with a complete response. So it's the first case. And so what is the significance of this report? So immune checkpoint inhibitors have not been commonly used for atypical pituitary adenomas and pituitary carcinomas. We mentioned that there were roughly 4 or 5 other cases, case reports, as temozolomide remains the chemotherapeutic agent of choice. We also previously discussed that temozolomide is not a great, really a great agent when you look at objective responses. So that's 40 to 50% of patients. So that's not even a complete response like what we had in these patients. Response is considered when that tumor shrinks from the temozolomide. So in this case, we had complete resolution of the tumor and the 6th nerve palsy. So treatment options for temozolomide refractory pituitary carcinoma and atypical pituitary adenomas are currently limited, and the prognosis is poor. Expression of PD-L1 in functioning pituitary adenomas or tumors with a high Ki-67 index potentially predicts susceptibility to PD-1, PD-L1 inhibitors. And so this is an area of active investigation. What DNA can we look at in the tumor to gain a better sense of whether or not this tumor is going to respond to immune checkpoint inhibitors? So our patient was found on next generation DNA sequencing, so state-of-the-art DNA sequencing, to harbor a mismatch repair deficient hypermutated tumor. And so tumors with this type of profile, there is evidence to suggest that there's increased sensitivity to checkpoint inhibitors across different cancer types. So not pituitary tumors, but across different types of cancers like melanoma and other forms of cancer. So this data formed the basis of what's called tumor agnostic FDA approval for the PD-1 inhibitor, different immune checkpoint inhibitor, pembrolizumab. And so in summary, so aggressive pituitary neuroendocrine tumors typically recur following surgery. Even when gross total resection is achieved, the tumor that we discussed in this case is the most aggressive tumor that I've ever seen in terms of the Ki-67, the most aggressive pituitary tumor. So treatment of aggressive pituitary neuroendocrine tumors with temozolomide is often limited, as it was in this case. Next generation DNA sequencing can help to identify potential susceptibility to newer agents like immune checkpoint inhibitors. While this study demonstrated complete resolution of tumor following treatment with immune checkpoint inhibitors, further studies will be needed to establish immune checkpoint inhibitors as a safe and efficacious treatment for aggressive pituitary neuroendocrine tumors. And so even though there was really an impressive response to the medication, in this case, further study is going to will be necessary. So with that, I'd like to thank you for your attention. And I think Dr. Zuccarello and I would like to open it up to any questions at this time.
John, before we open to questions, I would like to give a pretty simple message to patients who have been suffering from pituitary tumor or eventually need to have surgery. It's clear from this presentation, which is truly spectacular from Dr. Forbes, that we cannot limit our knowledge to just look under the microscope and say, oh, this is a tumor which is producing prolactin, this is a tumor is producing growth hormone, and move on. The technology has made a tremendous step forward. We need to look at the genetics of these tumors. So, and sometimes you can find really big surprises because if we have now looked at the genetics of this tumor, if we have now looked at the tendency of the tumor to have a fast growth, we may not be able to treat this tumor. So if you are, or you already did it, you are going to have surgeries, you really to start asking those questions. Can you send this, especially my tumors, to genetic studies? Because that will, in a case like this, in other case, it can truly limit or rather the opposite, allow a resolution of your problem. So that's the main message. There are a lot of information in this presentation that difficult sometimes to, because there's so much of technical names and so forth. But immunotherapy is something almost everybody knows. It's been now used for lung cancer, for melanomas, many other cancers. Okay, so it may be in the near future, maybe a line of attack for aggressive pituitary tumor. So that's just a pretty simple message, but something to remember. Questions?
Yeah,
yes, sir.
So I would agree with you 100%, Dr. Zuccarello, and I think it's a great point. And I think that Dr. Zuccarello and I are very fortunate. We have an outstanding work with an outstanding neuro-oncology team. and so who are really familiar with these, with state-of-the-art evaluation and treatment. And so in this case, Dr. Shingupta was the neuro-oncologist. And I think that, like Dr. Zuccarello had mentioned, that these type of advances are really the future of treatment of cancers. And so we're very grateful to have access to this type of technology. And I'll say that I'm very grateful to have colleagues like Dr. Zuccarello and Dr. Shingupta at the University of Cincinnati. And so I think with that we can open it up.
Yeah.
Okay, thank you so much. We do have a question to start out our round of questions, and it is a little bit of a long one. I am a long-term craniopharyngioma survivor. I am concerned about getting COVID vaccines due to possible cerebral thrombosis as a side effect. I get an MRI about every 10 years. One radiologist had written that my Gothic array of veins at the base of the brain was interesting. Craniotomies in 1963 and 1964, followed by cobalt-60 radiation. And so I think the question is about the vaccine.
Well, I know that there's been questions about the hypercoagulability, which means the increased tendency of created clots for some vaccines, and particularly what I call the AstraZeneca vaccine was linked to a number of cases of clots created in the lungs eventually. A commission was appointed, and they found that was not really scientifically proven. But other vaccines like Pfizer or of course Moderna or Johnson & Johnson, they have not been linked to a significant increased risk in hypercoagulability. So I think the risk benefits seem to be in favor of the benefits to be vaccinated.
Yeah, I think I would be in agreement with what Dr. Zuccarello said. I think that that probably, and you know, it's always good to talk with the primary care physician who knows your medical history, which sounds like it's really complex, who knows it best. But I would agree with Dr. Zuccarello that you know, our understanding of COVID right now is that the risk of being infected is much lower in patients who are vaccinated, and in addition, importantly, to the risk of mortality. And so I think I would agree.
Okay, thank you so much. And we don't have any other questions. It was very well covered and very fascinating. We really appreciate your presentation.
Oh, you're very welcome. I like I said at the very beginning, I don't think this type of presentation has ever been given.
No, it was great.
And that's Dr. Forbes and I, that's why we thought, although sometimes they are concept which just a little bit above my head for sure, on the concept of immune system responses and so forth. But I think the message is very clear. We need to continue to refine our ability to have a molecular fingerprints of these tumors. So I think that this is important, and I think this is the future, like Dr. Forbes said, and we may be able to not only treat but cure many more people. That's the most important message, and this is what the mission of PNA is.
Yes, definitely. I agree. Well, we appreciate your time and your presentation so much, and this will conclude our webinar presentation today. We really appreciate everyone taking the time to join us, and if you missed any part of this webinar, or if you'd like to share it with family members or friends, it will be available on our website at www.pituitary.org after it is edited. There will be a brief survey after the webinar. Please fill it out to help us provide you with any information you need. And thank you for joining us, and enjoy the rest of your evening.